specialist with the Wisconsin Cancer Collaborative and will be facilitating this webinar today. We really appreciate you all taking the time out of your day, especially in this somewhat uncertain and chaotic time, to participate on this call. We are delighted to have so many new people join us today, along with our existing members. Before we get started, given that the Wisconsin Cancer Collaborative is relatively new to some of you, I thought I'd spend 1 minute providing a brief overview of our work. We are the Wisconsin Cancer Collaborative, Wisconsin's statewide comprehensive cancer coalition comprised of 140 organizations working together to reduce the burden of cancer for everyone in Wisconsin. We connect our members with the tools, support, and knowledge they need to create healthier communities. Our work is guided by the Wisconsin Cancer Plan, which acts as a blueprint for action. The Wisconsin Cancer Plan combines best practices, reliable data, and concrete action steps for health systems, leaders, public health advocates, policymakers, researchers, and all other Wisconsinites engaged in cancer work. If you are not yet a member of the Wisconsin Cancer Collaborative, we would love to have you join. Membership is free. You can visit www.wicancer.org for more information. Let's go over the agenda for today's call. Today's webinar will provide resources and information about COVID-19 and cancer treatment, and will also be an opportunity to hear how other cancer centers have been impacted and how they continue to address cancer treatment during the pandemic. You'll first hear from the Department of Health Services on the current state of COVID-19 in Wisconsin. We'll then discuss what we know about COVID-19 as it pertains to cancer treatment. We will then have the majority of our remaining time to turn it over to a few of our members to hear how their health systems are addressing cancer patients' needs during the pandemic. At the end, we'll have time to answer all of your questions. If a question cannot be answered today, we'll do our best to solicit the right expertise and follow up with answers. We have staff monitoring the chat box, and we will do our best to answer questions and address comments, but if we miss something, we will provide a recap in an email follow-up we intend to send out after today's webinar. With that, I would now like to introduce Dr. Mark Wagner. Dr. Wagner serves as the Chronic Disease Medical Advisor within the Wisconsin Division of Public Health at the Wisconsin Department of Health Services. In addition to answering questions you may have today about COVID-19 and cancer, Dr. Wagner will provide us with a brief update on Wisconsin's COVID numbers as of Wednesday, May 13th.
Thank you, Alex. I appreciate the opportunity to provide the update today. The Wisconsin Department of Health Services continues to provide daily updates on the number of COVID-19 cases in the state, and we publish the data at the link that is found on this slide in the bottom right-hand corner. And you can also access it by visiting dhs.wisconsin.gov. And the numbers are updated at 2 o'clock every day. So as you can see, so we haven't, of course, updated for today yet, but as of yesterday, Wisconsin had 117,000 negative test results, and almost 11,000 of those results were positive. We've had about 1,900 hospitalizations and 421 deaths. And the map, as you can see on the right-hand side, is also from the DHS website. And you can see that as of yesterday, 68 of Wisconsin's 72 counties have positive cases reported. And that doesn't necessarily mean that there aren't other individuals in those areas that haven't reported that may have illness as well. But we have 68 of the 72 counties have confirmed positive cases. We continue to collect data and in different ways, and one of the things we're trying to look at is how many of the patients may have underlying health issues such as cancer, but I don't have anything to share, unfortunately, at this time with respect to that. But we'll continue to look to better understand the trends, specifically in some of these more vulnerable populations, and then report that information when it's available. And on the next slide, speaking of more vulnerable populations, as you remember from last month when I had updated everyone on the numbers, we were seeing racial disparities that were quite significant. And although in the month since then, the numbers are slightly better than when I shared the information with you last month, significant disparities still remain. And maybe some of the decrease in the slight decrease in the disparity from where it was before, maybe from the fact that when I spoke with you last month, the majority of the cases were in Milwaukee County, and now we've probably seen more spread throughout the state. So it might have evened out a little bit with that, but we still are seeing those significant disparities. So that's something we'll have to try to continue to address moving forward. Overall, the trends in cases, we continue to see the cases rising, but the percentage of positive test results have dropped over the last week or so. So that's a good sign. And when we look at some of the criteria, the gating criteria that we had for moving to the different phases in Badger Bounce Back Plan, we actually are at a point where we've satisfied 5 of the 6 criteria. We're just looking right now at the downward trajectory of influenza-like illnesses reported within a 14-day period has not been met at this point. And you can see the summary of all that data as well on our website under the Badger Bounce Back Plan. So as the chronic disease medical advisor at the Division of Public Health, I'm going to continue to work with the chronic disease programs, including the Wisconsin Cancer Collaborative, to address any ongoing concerns and needs for the residents of Wisconsin with chronic conditions and cancer. And I'm also going to stay on the line to the end. If there's any specific questions that you have for me, I can do my best to answer those. Or if I don't have the answer right away, I can check with some of my colleagues at the Department of Health Services and get back to you. Thank you for having me on.
Thank you, Mark. We are now going to move along, and I would like to introduce Dr. Noel LeConte, who is going to discuss cancer treatment in the wake of COVID-19. Dr. Noel LeConte is an associate professor of medicine at the University of Wisconsin Carbone Cancer Center and the principal investigator for our program, the Wisconsin Cancer Collaborative. She completed medical school at the University of Illinois at Chicago and is one of only a few physicians practicing in the Midwest with dual fellowship training in both medical oncology and geriatrics. Dr. LeConte's clinical interests are in gastrointestinal cancers and cancer of any type in older adults. In addition to the Wisconsin Cancer Collaborative, she is also the principal investigator for multiple federal grants, as well as clinical trials of new chemotherapies for gastrointestinal cancers from phase 1 through phase 3 studies. Dr. LeConte serves on various committees at the American Society of Clinical Oncology and has become a national leader in researching and raising public awareness about the connection between alcohol consumption and cancer risk. With that, I will hand it over to Dr. LeConte to discuss cancer treatment in the wake of COVID-19.
Am I advancing my own slides?
I'll move them forward for you.
Perfect. Thank you. That intro sounds a lot more impressive than I look, having not had a haircut in 3 months. So thank you for that, Alex. That was very kind. I wanted to, before we got too deep into treatment, address a resource that's available. Myself, along with staff in the Cancer Health Disparities Unit here at Carbone, did about 45-minute webinar around COVID-19 basics, prevention, and resources in the Black community. And you can see many of the faculty members featured on that slide. So feel free to use it. The address is at the bottom of the slide there. It's meant to be shared widely. And it will be going up, I believe, on the Carbone social media pages this week or next week too. So I was asked to speak about what our cancer center is doing in the wake of this viral pandemic. So the first thing to know is that it's been a little bit of patchwork, and so not every center is doing it exactly the same way, but there are some unifying themes. Many major cancer centers have implemented a lot of strategies to try to reduce the risk both to the providers as well as the patients. It does seem like patients on active treatment, and that's defined as recent chemotherapy, immune therapy, radiation, or surgery, are at higher risk. So for example, just to tick through these various strategies, one is screening all patients and staff and visitors for any COVID-19 symptoms, but that also includes taking everybody's temperature, sometimes multiple times a day. Some centers are testing all their patients for COVID-19 prior to starting new treatments. That I would not say that's been a universal approach because access to testing has been spotty. We are trying to minimize follow-up visits and ER visits as much as possible. What that can look like is telemedicine visits or pushing out follow-up surveillance visits from 3 months to 6 months. It's surprising how little data we have to drive those recommendations about follow-up frequency, and so we've been sort of pushing them out as long as we're sure the patient isn't having symptoms and is okay with that plan. Many cancer centers have established cancer patient-only rapid assessment clinics for symptoms that might be COVID-19. Thankfully, we have not seen a ton of use with that clinic here at the UW because we just haven't had the same level of penetration because social isolation is working. And so I think the most strong recommendation here would be we should continue to support and encourage ongoing social isolation as a way of protecting our patients. But most larger health centers do have kind of an offshoot of the ER where cancer patients can rapidly be assessed. We are requiring staff to use PPE, masks and face shields, universal gloving and hand hygiene, but we're also requiring patients and visitors to wear masks. We are limiting visitors. Initially, it was no visitors at all. We at UW have since lightened that up to 1 visitor with patients, which has added to the complexity of social distancing in the waiting rooms, and I think that that rule may be changing. All along, we have allowed patients that were near the end of life to have visitors, but I am aware of some hospitals that do not allow that either. As I said, we have developed in-house COVID testing at UW Health. I think most people on the call are probably aware Dean County has drive as the Alliant Energy Center. You can go get testing as a community member now too. For us, in-house testing is taking 4 to 6 hours to result. And we do have antibody testing available widely now too for UW Health patients and staff. We are recommending all staff be tested for antibodies to understand who may have some immunity, understanding that we don't know enough about this virus to know if that's long-standing immunity or temporary immunity. We are transitioning patients to oral chemotherapy regimens where possible. This has become more complex as people have lost their jobs and had changes in their insurance coverage, as oral chemotherapy can often have a significant copay burden. But where we can, we're trying to put people on oral meds. We're also trying to use shorter courses of radiation, so higher dose per fraction or SBRT over conventional external beam radiation to limit the number of times they need to set foot in the hospital. As I said earlier, we are really, I think one of the more amazing things about this outbreak from a cancer doctor perspective was the extremely rapid implementation of telehealth to our patients. It's been something we've been talking about. I've been a physician for 20 years, and I would say for most of those 20 years, we've been talking about it as an aspirational thing, and now it's here. A few of the hiccups has been that many televideo platforms are not HIPAA compliant, notably Zoom, WebEx, FaceTime are not HIPAA compliant, and I am aware that certain regulatory bodies have said that they will waive that requirement during the pandemic. However, I would note that our lawyers do advise us that that is not adequate. And so we have used an HMR-based video platform, but different centers are doing it differently. Reimbursement is also rapidly changing. Phone visits initially were billed at a very low rate, virtually unpaid rate, and that has changed retroactive to March 1st, where we're very, very hopeful that reimbursement will be near to an in-person clinic visit, therefore reducing the incentive for people to be seen face-to-face. Probably everybody on the phone is aware that health centers have had a big loss in revenue, which everybody is worried about. So that was a little bit of good news, although I have not seen the details behind that decision. Devil is always in the details. There are multiple COVID-19 hotlines and response teams that people can and should take advantage of. I think one strong message for patients is to call or to MyChart or similar kind of operation message first. We really don't want people just rolling in for a face-to-face visit unless they really need it. And I think every single cancer center has placed restrictions on employee business travel. The largest meeting of oncologists was supposed to take place later this month and has been made completely virtual. It's a meeting of about 45,000 people. So we'll see how that goes. Sure to be exciting. So in addition to the above measures, ASCO, which as Alex mentioned on several of their committees, they have recommended where possible that we do home collection of routine labs and home infusion of chemotherapy. I think our home health procedures are not quite caught up to that recommendation, although I agree with it in theory. And I would note there are some kind of novel lab tests for cancer patients looking at circulating tumor DNA, for example, where the company themselves have built out a home testing process and team. So I'm also hopeful that this will be another good development for cancer patients, which is to say to lower their burden of travel back and forth for testing. I would note, and there's the resources listed there for one of these studies, that a study out of Wuhan did make a strong recommendation that we continue to take aggressive measures to reduce hospital visits for patients with cancer during the epidemic, because it does look like cancer patients, in particular patients on treatment within the last 40 days, do significantly worse once they land in the hospital with COVID. So the next slide here is about what considerations should we be taking right now as we start to think about reopening a little bit or getting patients back into treatment. I think one thing that became abundantly clear when we thought it might be a 3 or 4 week rapid increase in COVID cases was that we were able to push patients up by a month. But now that we're out to month 3, I'm seeing a lot of these patients now getting hospitalized, having symptoms of progressive disease, clearly needing to be on treatment. And so the lesson there is that cancer doesn't stop even for a global pandemic. So we need to think about how are we going to get these patients back on treatment if they need treatment, if they're not in surveillance. I still think reducing the frequency of in-person visits as much as possible is going to be critical. And so some things that we can do is continue to be mindful about oral chemotherapy and encourage our patients to bring that up as a possibility, or their family. We want patients to really utilize telehealth, and that may include and has included us providing some level of IT support to patients who maybe don't know how video chatting works or what the benefits are. I can tell you as a physician, assessing patients for chemotherapy toxicity on the phone versus being able to actually look at their hands and look at their skin and kind of get a sense of their breathing patterns, it's a pretty dramatic difference in terms of safety. And so I would say for patients on treatment, always doing a video visit is preferable if possible. We would encourage patients to ask about how the healthcare systems are trying to limit the spread of COVID-19 within their center. And we would also encourage patients to inquire about the ability to do virtual second opinions. I think most large cancer centers are up to speed with that now. And myself as an oncologist, I always welcome second opinions. And so I don't want people thinking that those have stopped happening. They are definitely still happening. If we are seeing a referral for a patient who has a local oncologist, we will in fact encourage them not to do an in-person visit with us so that they limit their exposure. We really are trying to keep in-person visits for patients that are going to need to be treated at our center. Patients should inquire about home lab monitoring or even monitoring at a smaller facility that likely is safer for them. And then reducing the frequency of port flushes. This is really getting in the weeds, but is a perfect example of, why we do things the way we do, how much is style versus how much is evidence-based. We always flush people every 4 weeks for their chemotherapy ports, and as it turns out, you can actually flush them every 12 weeks, and there's good literature about that that we can share with you, but that would also reduce at least 2 out of 3 visits over a quarterly basis. We want to encourage patients to do universal masking both in their community as well as in the hospital, and we want to work with patients to either try to work from home or to take a leave from work. And so patients often are not asking about that, and so it's important on the cancer care team to mention to the patient, where are you working? Can we help you change that so that you have a safer structure to work from home or take a leave from work? Did you want me to keep rolling here, Alex? Did you have an intro?
I was just making sure that you had finished everything there. But thank you, Noelle, for that really great update. We're going to switch gears just a little bit, and we're going to highlight a few members and discuss what changes their health systems have made. I know we already heard a little bit from Dr. LeConte at UW Health, but we're also going to hear from Chris Gooch from Marshfield Clinic. Noelle, did you have anything else that you would like to add to changes that you have been seeing at UW Health? Great. Why don't you go ahead and start us off then?
Yeah, sounds good. I think as we're reopening, we're really trying to think about how to incorporate telehealth, but also incorporate social distancing in the workrooms. For those healthcare providers on the call, you'll be familiar with the fact that workrooms are often not that different from sardine cans, and that we're often kind of elbow to elbow at these computers. And so thinking about how do we really maintain that 6 foot of distance that we're supposed to have. One strategy has been to blend telehealth visits and in-person visits as much as possible, and structuring them rather than me having a whole day clinic. I might just do the morning clinic in person and do the afternoon clinic telehealth, and do that from my academic office rather than in the workroom. And then I would, my partners would work in the afternoon to do their in-person visit. The problem with that is that telehealth visits often are on time and are functioning quite well right now where everybody is at home. But once people start going back to work, it's going to be more challenging. Additionally, the clinics don't always run on time for things that are out of control of the provider. For example, if the lab gets backed up or somebody hits traffic on their way in or there's a detour. So one strategy would be to do 2, for example, telehealth visits and then sandwich an in-person visit in between to hopefully provide some flux there. We think the in-person visits are the most likely to run behind, but then you don't want to kind of back up your whole day. So that would be one strategy. Another one is having patients room themselves. So as soon as the patient arrives, rather than having them sit in the waiting room and wait for the medical assistant to come get them, have the patients physically put themselves into the room, and then we will meet them in the room. I think psychiatry practices in particular were already doing a very similar model, and so we're looking to them for guidance. We think it's important to prioritize people with new diagnoses of cancer for their first visit to be in person. Many of us have tried to do these over video, and it is very, very, very challenging because there's a lot of questions, there's a lot of technology issues. We can't share with them educational materials very rapidly because it formats funny in the MyChart system. So we are encouraging new diagnosis patients where we're going to be the treating team to actually come and meet us in person the first time. And then we're recommending that every patient on treatment at least have one in-person visit about a month if we can swing it. Usually on the day they're already coming for chemo, so they're already going to physically be in the building. There are also really important telehealth considerations for patients who live outside of Wisconsin, particularly Illinois, that I would want people on the call to be mindful of, that for most of us, we don't maintain both Illinois and Wisconsin licensure. And so we are not able to see quote unquote, to do telehealth visits for patients who live in Illinois. So we are requiring those patients to either drive up and see us in person, or we're recommending an Illinois provider that they can see, potentially with telehealth. And then I did want to touch a little bit on clinical trials. So most clinical trials ground to a pretty rapid halt with COVID-19. We have continued to on a case-by-case basis, consider patients for trials. Of course, our trials are largely therapeutic trials, meaning there's a potential benefit to the patient, and so we are able to continue to enroll patients. But there are some logistic issues with our coordinators being off-site by and large, and things like so-called wet signatures. And so it's been a process of working with the sponsor and the regulatory bodies to help them understand the difficulties, and I think it has pushed clinical research forward in terms of using technology well. But just to remind people, that is federally regulated work, and so you need to be careful about significant deviations. So I would say at this point we're doing it case by case for patients, and we are not reopening any non-therapeutic trials at this time. The last thing I wanted to touch on was universal testing for patients on chemo. I think this, for COVID, I think this is the right approach, but I think that we still are behind on testing. We're also behind on PPE, but that's a separate issue. But I think once we can expand testing, I think every patient should be getting tested before day one of each cycle would be the goal.
Great. Thanks so much, Noelle, for the updates. Now I would like to hand it over to Chris, who is the Regional Oncology Manager at Marshfield Clinic. Chris, do you want to unmute your line and take it away?
I can. Can you hear me? Hello,
Yes, you sound great.
Oh, thank you. Again, thank you for the opportunity to share some thoughts, provide some reassurances, and maybe some insights. A lot of what Dr. LeConte spoke to already, our health system is doing the same. I was kind of asked to speak about rural aspect of it, from what we're doing in rural communities to make sure that our cancer patients are still being seen and taken care of. But before we get started and getting into those details, I'd be remiss if I didn't kind of talk about how the communities came together and continue to stay together to serve our large areas with a lot of limited services. You know, just like the Cancer Collaborative is all about coming together like we're doing today, you know, learning from each other, taking action, trying to improve health. I have to say that the local communities here in Western and Northwestern Wisconsin, when this pandemic hit, truly came together and worked collaboratively. And a lot of credit goes to our public health departments and the counties we worked with. At one point, our health system was in Western Wisconsin was part of 7 different joint county incident commands working together for cross-county coordination. And Eau Claire County, especially the DHS department, they jumped on this right away, got out ahead of things, started planning, and eventually provided a lot of guidance to other counties. One of the things that we did collaboratively coming together was all the health systems started meeting regularly with DHS, share ideas. There were no secrets. What are you doing? How are we going to do this? And then I think one of the things that really helped the communities was daily press conferences that came out from DHS, really to help guide the communities about understanding the stay-at-home orders, what's going on, providing facts, and built that trust. And, you know, it was nice to see the media support this. And I think that helped provide a sense of calm in the uncertain times that we were, especially in the beginning, and still are to some aspect. And, you know, when we look at a lot of the smaller rural communities, their local hospitals are challenged just because of a resource limitation, whether it's equipment, whether it's advanced skilled nursing resources. So we kind of work together with a lot of the critical access hospitals to create plans to keep people in their communities with the surge planning that occurred so that we could transfer rural patients to the larger hospitals if they needed the negative pressure rooms, excuse me, or if they needed advanced nursing, and then be able to transfer them back when they were clinically cleared. That was all part of the larger rural community planning for the tiered surge planning on the beginning. Thankfully, we've not seen that surge in our area, so we've not had to utilize that, but are certainly ready to move forward. And then as far as what are we doing for our cancer patients, a lot of what was already discussed, doing the same thing. We looked at all of our appointments that we had scheduled and figured out who can we push out, maybe delay their follow-up appointments. If it was a 3-month, maybe push it out another month. The 6-month, maybe we pushed it out another month, again, to keep them at home. But for our health system, we've been using telehealth for a long time, but nothing to what we're doing today. And we too are offering telehealth visits. A lot of them are the follow-up visits, the on-treatment visits, if it's a follow-up visit, offering the telehealth. There are some limitations with telehealth, not only to what Noelle spoke to from a regulatory perspective, but in our rural communities, broadband. You know, are they able to connect? Is it able to stay connected? And then, as Noelle spoke to, a lot of the staff had to be trained because we became the trainers of the patients of how to get their computers set up and become those IT resources. So that was quite interesting. The other thing that we did early on, there was a lot of concern with the cancer patients about, should we come in? I'm scared to come in. So we moved our social worker and our navigators into roles of doing a lot of those pre-screening calls and taking those calls to have those crucial conversations to help with anxiety and overall concern. We're still today calling our patients the day prior and doing those screening calls just to determine, do you have a fever? Are you having any symptoms? And then using that call to remind them that when they come in, the exact same things that are happening at UW. You'll be screened at the front door, having your temperature taken. You'll be asked to wear a mask, the visitor restrictions. And so they have an understanding when they come in. A couple of the other things that we've done is we decided not to eliminate all of our rural community outreach. From a cancer care, we're still going to some of the outreach sites and doing visits in person and providing cancer treatments there. A lot because of the disparities that those patients have getting access to care, transportation, but again, making sure that we're maintaining the social distancing and ensuring safe care. We've also utilized our NPs to review the schedules and work with the providers to help determine who could be delayed, who should have telehealth, or maybe just a phone call visit. We are not testing all of our patients prior to coming in for treatments. The only ones we're made that exception for is for our transplant patients. Those are getting tested. Talked about the screening already. And then from a facilities perspective, really looked at our physical space from where are the patients entering and exiting the building, making sure there's separation in different areas, whether it's the waiting room, in the exam rooms, how far distance are we? We put up plexiglass barriers at the check-in desk just to give another layer of protection. We changed our check-in process to doing some virtual check-ins. So we're calling the patients ahead of time and verifying the insurance and getting them checked in. The things that we can do without having them stand at the registration desk and standing there longer than they need to. Obviously enhanced our housekeeping, more rigorous disinfecting. And I think one of the key things also was educating our own staff. I mean, our staff, when this first came out, they were just as anxious as all of our patients were, and making sure that we educated them so that they were truly feeling more educated as to what our consistent message is, what are we doing, so that they could be the voice also providing that reassurance. We also ended up, our one call line that we had set up for patients to call in with questions became overwhelmed with a lot of the oncology patients. So those were switched over to our triage line, and then we staffed up to help those increase calls of just, again, should I come in? Should I be delayed? What do I need to do if I do come in? Let's see, I'm trying not to duplicate what you've already heard, so I'm just going through my list. Oh, one of the other things that we implemented for our radiation patients was they stay in their car in case we're running behind, and then we text them and say, now you can come in, so we don't, again, have people waiting in the waiting room or waiting in a check-in line. They're waiting in their cars until we text them to say, hey, you can come on in. We also did curbside pickup for prescriptions, again, so you're not having to stand at the pharmacy desk to get your prescriptions. We just have curbside pickup and we bring it out to the car. Let me think. Again, telehealth, as we talked about earlier and as already, that is going to be our future. We've definitely increased the number of telehealth visits in our entire health system, and then especially in oncology as well. With nursing home restrictions for our palliative care hospice visits, really looking at telehealth setup as well. And I think some of the lessons that we've learned is, we're still learning. Every day something changes. It's going to continue to change, just have that ability to be nimble. It's truly pushed all of us in our health system to think outside of the box. And then, as it's not only a national and global issue, but just right here in Wisconsin, the realization of the PPE resources and supply chain shortages that we're dealing with. And how do we stay on top of that if there was a surge and be planning for that? And then I think one of the things that was also reassuring, tying back into our communities, is ask and you shall receive. We started asking for homemade masks because we're asking patients to come with homemade masks, and we've received over 50,000 homemade masks. Other donations of N95s, hair salons that cannot do our haircuts that we're all wishing and we could have sooner than later, donating rubber gloves, just other donations. I think that just really sends a message about how strong we are in Wisconsin with our communities coming together. I think
Thank you so much, Chris. That was a great update. With that, now I think we will move into our Q&A section of the webinar, and I'll hand it over to our partnership manager, Beth, to facilitate.
Great, thank you, Alex. First, I just want to, as people are kind of thinking through questions and putting them in the chat box, I want to thank our presenters today, not only for presenting today, but just what you are doing to help patients in our state. These kind of extraordinary lengths that you and your systems have gone through. I have known you for quite some time, and I know how hard you've been working to do all of this, and it is who you are, but I want to thank you for everything you're doing. It is amazing what you have gone through to help patients in our state. So thank you for doing that. I just wanted to make sure I did that. But we do have some questions. So if I could maybe start off, this one is around telehealth, and you addressed it a little bit, Chris, but I wanted to see if you had any additional thoughts. So high-speed internet isn't always guaranteed, especially in those areas. So the video visits might not be able to. So is there any sort of workaround that you have put into place for those areas that might not be able to do the video visits?
If there's a telehealth does not work or someone's having trouble because their internet's not working, we're doing a phone visit. We are trying to determine what a possible workaround will be, because we know that phone visits, if you look at it strictly from a reimbursement perspective, is probably not going to continue to be reimbursed as a telehealth visit. So our telehealth teams are looking at different platforms. They've talked about iPhones and doing FaceTime, Skyping. Again, sometimes that still affects the internet broadband. So I do not have any answers today as far as what our system is doing, but if there's someone that would like to reach out to me specifically, I could probably get you connected. I know I can get you connected with some of our telehealth experts in our system.
Thank you.
Beth, the other kind of special populations to consider here would be the hard of hearing. Telehealth basically doesn't work at all in that population, either phone or video based. And so do we need to expose them to increased risk? Sometimes we do. If they're so hard of hearing that they can use a sign language interpreter, it's actually much easier to do it via the video. That works just fine in my experience. I've done it a handful of times now. I would say that libraries generally are very helpful in doing this pre-COVID, and so we look forward to working with them once libraries reopen. But many libraries still offer their Wi-Fi. They've kept it on, and so we encourage patients to do video over Wi-Fi versus cellular because the quality is much higher. But for those truly rural patients that don't have reliable internet, it's phone or in person. That's really the only thing we've been able to figure out. we're looking to our partners at the VA that have set up telehealth clinics in communities like in strip malls, staffed with VA employees. So the patient comes to this small kind of doctor's office, but there's no doctor there. It's a technician who can help even perform physical exam maneuvers, get vital signs, and then the VA equips those rooms with the technology needed for video health. That would be the other option.
Great, thank you. We have another question that talks about this individual has a team that is working with prostate cancer survivors and men on active surveillance. They are currently planning for when Wisconsin reopens again and expect that the men will be apprehensive. Do you have any thoughts on what you could say to ease their minds on kind of coming back together? And or what will we do? They'll do as much virtually as possible to mediate as much contact as possible. So maybe some thoughts on how to ease people's minds or thoughts on how to bring people together virtually.
And this is for support groups or this is for treatment?
It sounds like it is a group with cancer survivors and those on active surveillance.
Okay. I think trying to maintain social distancing if you do choose to meet in person is important. You know, sticking by the DHS requirements as far as number of people. I would actually turn to Gilda's Club for how to do virtual support meetings. My sense from my patients is they're doing it quite well. I don't know if anybody from Gilda's is on the line and could jump in, but and I think as far as reassuring people when it's time to meet in person, I think in person probably provides a richer experience for most people. If we're all masked and doing hand hygiene and sitting 6 feet apart, the risk is likely to be pretty low, and the benefits of participating are likely to be high, especially for these men. I'm familiar with that population. So I think just, you know, continuing to rely on the data and the support of the DHS team as far as recommendations and making sure we're screening everybody before they come for fever or any symptoms would be the strategies I would use. But I think it's important to not ignore cancer. Not everything has to be put aside while we're dealing with this pandemic. In fact, it probably shouldn't. So I would encourage them to keep thinking about ways to keep moving forward.
Great, thank you. Another question came in that are there any specific initiatives or recommendations that cancer centers are doing to help educate family members and caregivers? So it must mean if they can no longer be in the room or they're actively engaged in those appointments, are there things that can be done with those family members and caregivers?
I think I can speak to what we're doing at the pre-screening calls. I think re-educating them that here's kind of what our visitor restrictions are. If we need to do a speakerphone so that if they're sitting in their car, they're at home, do a speakerphone on their, and so when they're in the visit, but they're not physically in the room so they can hear the message that's going on. I think that's important. And then just doing the follow-up calls with asking the questions, did you have anything more? Or on the pre-screening, understanding what they need. If they have a bunch of questions, then providing that to the physician ahead of time so that when they do that telehealth visit, they know that there needs to be a portion of here's why we're doing what we're doing, here's how you need to take care of yourself. Again, social distancing, hand washing is what we're expecting. So I think just more on the being proactive on the front end, if it's through pre-screening calls, educating them so that they're hearing the consistent message, and then when they come in, they're getting the same message. I think that's what you're asking for, is how do we educate family members on the recommendations? I could be taking the question wrong too, but.
No, I think that's great. Thanks, Chris.
Beth, I had a couple thoughts. The video platform that we use through our EMR is a hyperlink that needs to be, that you can access through a web browser. And so we allow patients or encourage them to share that web browser with family so that everybody can join. And this week I had 16 16 people on the same call. It was like the Brady Bunch, where there were like all the boxes lined up and there were little heads in every box. It was quite something. But I think in this time where we all feel very isolated and alone, it really helps for everybody to hear a consistent message. We try to write, you know, summaries at the end that go into their My Chart that they can then copy and paste into an email. But I think it's always better if everybody can hear it straight from the horse's mouth right from the beginning. So that's been our workaround, is to encourage people to share that link, have people on the call with them. The platform we use, we do have the ability to have people drop out if we're going to start asking sensitive questions or ask them to join 15 minutes later, for example. It's been remarkably helpful with our AYA patients, adolescent and young adult patients, where consistency of messaging between parent and young adult is really important. And then we're doing the same, where we're video chatting either in the chemo room with iPads that we have, or we're putting people on speakerphones. Again, some HIPAA considerations there if you have a wide open chemo room that just has chairs. But we're doing a similar thing to what Chris was describing, where we can.
Noel, what is your platform that you're using that you can do the Brady Bunch aspect?
It's called VidYO, VIDYO. My understanding is it's an Epic platform. And I can connect anybody who's interested with our EMR team if they want to learn more.
Thanks.
Great, thank you. Deborah, this was a Deborah Neville's question, so I just wanted to make sure that Deborah felt like that had helped. Please let me know if there is some additional information, and we can keep going on that one if there was more questions around the members and caregivers, or family members and caregivers. Thanks, Deborah said that was it. Okay, so another one around our cancer centers actively collecting data on the modifications to cancer care that have occurred. So for example, moving from infusion to oral agents, so we can learn more about what modifications might be beneficial or detrimental.
That's an awesome question. Yes, we have formed, I mean, this is probably not the right word, but a collaborative of sorts with other comprehensive cancer centers to track this in real time. And then some of the Carbone faculty have a survey of patients and the family's perspective on these changes that should be going live as soon as we get IRB approval. So we have both a national network and then a local approach to try to understand effect on patient, effect on families, and then outcome outcome changes. I think it's going to be difficult to interpret survival data because there were lots of patients that were offered chemo but told, I think rightfully so, that that would increase their risk of a bad outcome from COVID, who then chose no chemotherapy, who of course, had worse outcomes because of that choice. But it is something we are keeping our eye on with those caveats in place.
Great, thank you. Another question more specific to radiation oncology came in around how other radiation oncology sites are treating PUI patients. So I don't know if that's a specific term.
Yeah, PUI is a person under investigation, meaning they have symptoms suspicious for COVID and they're being tested, but the tests are not resulted yet, or the more definitive test called a PCR is in process. We are not radiating PUIs if they're in the hospital because our testing is usually back within 1 business day. We are deferring the radiation for 1 day to get the testing. If you are needing the PCR testing, the more confirmatory testing, usually that means you're in the ICU, in which case you're not getting radiated anyway. And we are doing universal masking of both patients and then all of the healthcare team in the radiation suite area. And we are screening patients on arrival for temperature and no visitors with radiation. They're being asked to wait in the waiting area or in their car. But I think for a true PUI that's not community-based, we would not generally radiate them.
I would agree what Noelle said from our system.
Thank you. It looks like one last question, so please enter in questions if you still have some. But the one I have here is a clarification on, it looks like if an individual with active cancer is diagnosed with COVID and then passes away, how is the decision made to count the death as either a COVID related or is it attributed to the cancer?
I'll start. It's a really great question. This is a very practical, real-life question. We've been doing it as a team-based decision. Usually this happens in the ICU. So with the pulmonary critical care, anesthesia critical care teams, discussing the patient's symptoms and course and trying to understand if it's COVID related. We're starting to understand what those deaths usually look like. It's things like renal failure, respiratory failure. And then we factor in where are their tumors, what kind of cancer do they have, what treatment have they been on, and trying to understand kind of time course. But I would say in the vast majority of cases that I've been involved with, it's been pretty clear that it's the COVID, meaning they were doing okay from a cancer perspective, stable disease, et cetera, on scans, and then they come in with a viral illness and they're COVID positive and they end up on a respirator or ventilator, and then they die. But yeah, we're doing it as a team approach here at UW. And then we do put on death certificates, you can put a secondary cause, and so we do list the cancer there.
From our health system, we'd be doing the same team approach with ID departments and evaluating it, looking at all the contributing factors. We're thankful because we have such low numbers up in this area. I think it would be evaluated as from a team approach and determine, is it COVID related or is it related to cancer or jointly, as Noelle stated.
Great, thank you.
It does bring up one point to me, Beth, that this has been an opportunity for us to really talk about advanced care planning with our cancer patients. I personally have made sure that all of my patients that I've been communicating with have a healthcare power of attorney, and that we have it on file, and that the one we have on file lists the decision makers they would want. And then we do have, through our palliative care team, the ability to do phone-based or video-based advanced care planning around what if I get COVID. And I was a little apprehensive at first, thinking patients may not like that, but the vast majority of my patients have actually really welcomed the conversation and felt reassured that they still have a little bit of control over all of this. And that conversation is specifically geared towards their cancer treatment. It's not just a generic COVID conversation. So I think that, again, it's all about preparation and prevention here, but trying to prepare for the what ifs if it does happen. Also relieves some of the burden on the family having to make those decisions if they've never had that conversation.
Great, thank you very much. And I think that leads into kind of one of my last questions is, how can we as collaborative members and partners with you in the community, do you have ideas on how we can continue to support your work, support patients, you know, in these very difficult times, in either helping them feel supported as they go in for treatment or just in their communities? If you have any thoughts or ideas for us as members that we can help support you in your work.
I said this on the last webinar, but since I think there might be different people, I just want to reiterate that social distancing and wearing masks is an act of love, and it's an act of love for our cancer patients, and it's saying to them that we don't want them to get sick. And so I think continuing to support social distancing, I know there was a big Supreme Court decision yesterday, but I think continuing to support social distancing as much as we can, continuing to mask out in public, continuing to be aggressive about hand hygiene, calling people out when we see people that aren't doing it, is really protecting our patients who are terrified right now. So that would be my main recommendation. I think supporting us in continuing to get personal protective equipment would be very helpful. We do not have enough right now, and that would be another helpful strategy. And then I think working against you know, bad messaging or incorrect information where you see it, whether it's your Facebook feed or your family members. Certainly handmade masks where those are requested. Their food pantries still very much are in need of donations, so considering, you know, continuing to do that. It certainly is affecting our patients. We're expecting about 20 to 30% of our patients are going to lose insurance, and that's going to have a big impact on cancer patients. So continuing to support those community resources is helpful too.
I would completely support all of what Noelle is saying, the social distancing, the wearing the mask. I think also embracing that medicine might look different. You know, the care is going to be the same. You're going to get quality care, but with telehealth and phone visits, that's a new norm. And I think that's going to be important. Remember and support your neighbors. And I think just having a consistent factual communication and then not forgetting to celebrate the successes and lessons learned along the way through this pandemic, because we're writing part of history. And in healthcare, there's always one constant, is that it's changing. And I think in the last few months, we could have never expected to experience the change like we have, and to stay strong and be resilient.
Thank you, Chris. I think that is a very appropriate way to end the conversation. So I will turn it back over to Alex to close us out.
So just a few wrapping up notes. We do have another June networking webinar coming up. On June 11th, we will be talking about COVID-19 cancer screenings and vaccines. And the description of this webinar is, in response to COVID-19, fewer people are visiting their healthcare providers. How can we ensure patients are still getting the cancer screenings and vaccines they need? This webinar will examine cancer screening and vaccine delivery challenges and opportunities resulting from the pandemic. So June 11th from 10 to 11, and registration is open for that now. And then lastly, I wanted to highlight a brand new resource we just debuted on our website this morning. We now have a new COVID-19 and cancer social media toolkit available. We have 5 different messages, and we have some branded with our logo, and then also some unbranded so that you may put your own logo on them. And you can check these out at the URL I have listed below. And then lastly, we want to leave you with a few resources you can turn to for more information on COVID-19 and cancer treatment. And these can be found online at our website as well. So thank you again all for taking time to join us this morning. We will make the slides and recording available later today. I hope everybody has a good rest of their day. Thank you.